And for our first speaker this afternoon, it is my pleasure to introduce Dr. Tom Moorcroft. Dr. Moorcroft did his undergraduate studies at the University of Vermont before attending the University of New England College of Osteopathic Medicine. While at Unicom, Dr. Tom was selected to complete a one-year fellowship in osteopathic manipulative medicine. Dr. Tom completed his residency training in family medicine at Middlesex County Hospital in Middletown, Connecticut. Dr. Tom is board certified in family medicine and osteopathic manipulative treatment. Dr. Tom has been fortunate to have many amazing mentors who have helped him continue his lifelong learning for the benefit of his patients. Tom deeply believes that the true source of radiant health is within each of us. Dr. Tom serves on the teaching faculty of the Osteopathic Cranial Academy, as well as the OCA Board of Directors. Dr. Tom serves on the Connecticut State Pandas and PANS Advisory Council. Dr. Tom lectures extensively on osteopathic philosophy and treatment, Lyme disease and other chronic infections, pediatric tick-borne illnesses, integrative medicine, and nutritional approaches to healing.
Please, let's give a warm welcome for Dr. Tom Moorcroft.
Thank you guys very much. It's a real pleasure to be here. I am board certified in family medicine and osteopathic treatment, and today one of the things we're going to talk about is sort of the unique osteopathic philosophy. It's a little easier when it's on a lob, when it's not working, so just remind me if it gets too low. Throughout my training, it's been really cool because in osteopathy, mentorship is very prominent, and we pass on hands-on treatments from one generation to the next, with our mentors always wanting us to go one step further than they have. And the same thing happens in the group of people who treat Lyme and chronic tick-borne illnesses. And today, I have the honor of speaking before, and also the ability to get a little extra nervous because Dr. Horowitz is here, and he's one of my long-time friends and mentors. And he started me off. I did the physician training program through ILADS with him, and subsequently with Charles Ray Jones. And these two gentlemen have been around for a long time, really helping me, develop as a clinician. And then I try to, bring in all the different things that I've been experiencing through my osteopathic training as well, and bring that to our patients. And so it's just an amazing thing when people get you started, and then the next thing you know, you're on the ILADS board, and then you're on 16 committees, and then you're one of the physician training preceptors. So, is that okay for you guys? Because it's like super loud in my ears. I just want to be sure. Yeah, it's fine. It's just I sound like I'm screaming at you guys. So anyway, the thing is, now I'm doing the training that Dr. Horowitz did for me, but we still stay very closely together. And he continues to be a mentor, and I really appreciate that. So a lot of the information that I'm presenting today comes from Dr. Horowitz and some other people, and then I'll put my personal flair on it. And so, to get started today, what I want to do is talk to you about tick-borne illnesses, particularly co-infections, and I see a lot of children, so we want to have a little bit of an emphasis on that in children. And in osteopathy, we have a kind of a unique perspective on health and healing, is that the body always tends towards being healthy. So we want to explore that a little bit today. And so what we're going to do is we're going to start with the parts, and we're going to just look at some of the co-infections. And I think these are super important, particularly as you'll notice where you guys are in New York. You're going to see a lot of different things than I might see in Connecticut, even though we're neighbors. So that's an important thing to think about. And then I want to spend some time talking about things that might be tick-borne illnesses. They might look like it, but they're actually not. And then I also want to talk about some things that a lot of people don't think are tick-borne illnesses, and they actually are. So that's, I think, an important take-home point. And then, again, as an osteopath, I want people to get better, and I want, there's this balance and harmony that our body is always trying to achieve, and I want to try to figure out how to get our patients to that place, not just going, oh, you have Lyme, okay, here it takes, 4 years of antibiotics and you're cured. So with co-infections, one of the most important things is that the usual hypothesis is that a single bug is going to lead to a single disease. And this is going to be consistent and reproducible on all hosts. So you get bit by a tick, you have babesiosis, you're going to have night sweats, and you're going to have anemia. We're going to give you treatment, and you're going to be good in 10 days, and that's it. But the clinical reality really is that multiple bugs are usually present in these ticks. And when we, so then we have maybe a complex presentation of that looks like many different illnesses. We have, that overlap between Lyme and Bartonella, and sometimes even staph and strep. And people get other things when they have Lyme too. I've had people come in with no pulse in one of their legs, and they tell me that, hey, my Lyme is acting up. Like, you don't have a pulse, you could lose your leg. You need to actually go get medical care for some other illness. So that's also an important thing. And the last thing there is, every individual is unique. Our genetics and our environment and our family life, those things all will sort of impact the way that we experience a particular disease. So Lyme in someone over here is going to be different than Lyme, and somebody over here is going to be different than Lyme in me. And that's an important thing for us to think about. So how do our immune systems react? I mean, most of our illnesses are described as, one bug infections. We experimentally infect something and we say what the problem is. But the reality is we have not a really clear idea of what happens when we have more than one bug that's infecting us. The other thing is our tests are designed the exact same way. So what happens when there's multiple bugs? Will those tests actually even be valid? And then what happens if we get the doxycycline 200 milligrams times 1 to make sure we don't get a rash, which has nothing to do with preventing Lyme disease? Now we go back and we have a hard to diagnose person, and maybe we can't even make that diagnosis. So there's a Yale study that said ticks and other natural hosts are commonly co-infected, which I think is really important. This is, Yale, one of the IDSA strongholds, but they also publish a lot of stuff, and they're telling us, hey, ticks are co-infected. But they go further, here, and they say that Babesia and Borrelia coexist in the exact same ticks. And then they go on to say that you can have more severe symptoms, sometimes making the diagnosis harder. So here we have mainstream medicine telling us that maybe if we have, our ticks are co-infected, and if our patients get co-infected, it's a lot harder for them to get better. And, folks like Dr. Horowitz and myself have been telling people this forever, but so here we go. In New York State, they looked at some, in Dutchess County, they looked at a couple, in one other county that I don't remember off the top of my head, they looked for infections in ticks, and they found that 71% of deer ticks had at least one infection, and 30% of them had multiple infections. And we had infections like Borrelia burgdorferi, Borrelia miyamotoi, Anaplasma, and even Babesia and Powassan virus. We have several other things here studies showing that multiple co-infections in the same ticks. And interestingly, on the one here, we see 27% are positive for Lyme and Babesia. And then this one from the Netherlands, Bartonella species have been found 70% of their ticks. So a lot of co-infection. And we have a whole slew of other studies here, and I could probably put more on that screen to show that ticks are infected by multiple different infections. So the real take-home message here is that our patients are most likely going to be co-infected. If they got bit by a tick that's got more than one infection, it's likely that they didn't just get Lyme disease. They probably got Lyme and Babesia and Bartonella and whatever else they had. So I think this is a really important slide. Now we're talking about co-infections, but what this is showing us is when Lyme happens. Well, as most of us know, and most doctors are going to report on their board exams, is that Lyme is going to be mostly occurring in the summer. But if you look at this more closely, like every single month here, the CDC is reporting that Lyme disease is diagnosed by doctors, every single month. And now, look at from 2001 to 2010, we can see here, those in their 40s to 50s are at high risk, but look way over here. We've got this spot, there we go. Greater than 25% of the people who are getting diagnosed with Lyme disease are our children, 5 to 10. I have a 6.5-year-old at home. How many people have kids at home, right? Lyme is paradomestic, meaning 75% of people are going to get it in their yard or their friend's yard. So going out in the woods, might actually be safer than playing in your own yard. So it's really important in my mind to look at what kind of ticks we're dealing with and know what kind of co-infections they may have. So if you get bit by a dog tick, you're unlikely to get Lyme disease. Is it possible? Sure, but it's unlikely. So here we see the Ixodes scapularis tick, or the black-legged deer tick. Gives us Lyme disease, babesiosis, anaplasmosis, and even Borrelia miyamotoi. Rocky Mountain spotted fever, on the other hand, is not carried by that tick. So, but if we get bit by a dog tick, we have Rocky Mountain spotted fever or even tularemia. And then if we look at the Lone Star tick, which is pretty common in this neck of the woods, we've got ehrlichiosis, we've got Rocky Mountain spotted fever, Striae borreliosis, and even Q fever. So, I mean, the thing for me is, when I got started, I'm like, why are people telling me to check for Q fever and tularemia? Well, this is why. And a lot of our doctors aren't really getting this in medical school, or if they are, they're not remembering it. So those pictures, as well as this one, are from tickencounter.org, and that's from the University of Rhode Island. They have a lot of good information there. They also have some information that I don't agree with completely. But what you'll see here is the tick activity from May 1st to May 15th, right? And the tick rate, encounter rate is already high. Okay, and if you look up here, we have Lone Star ticks are the #1 biting ticks in this area. So if we go back, yep, amazing, isn't it? So we live in an evidence-based medical society, and people say they follow the evidence, but they don't even know what it is, and it's very frustrating to me. So I think, our doctors really, they really need to start looking at what the actual evidence is. This took me about 1 second to find. I typed in TIC and it popped up at counter.org on my thing because I've used it before. I mean, it literally takes you 10 seconds to get to this website. Ehrlichiosis, Rocky Mountain spotted fever, Q fever, and even possibly Striae are things that you have to be a little more worried about here. But you also have dog ticks and deer ticks, so every single one of those are things that you might have to worry about. Whereas if you live in my area in Connecticut, we don't really have Lone Star ticks. So one of my pet peeves is this whole thing about transmission. Oh, you have to be bit by a tick for 2 or 3 days, or you can't get Lyme disease. Well, if we look at the evidence in animal models, transmission can happen in less than 16 hours, and we don't know what the minimum time is. So we don't know how short it is. However, there have been some research published that show that we can have transmission in under 24 hours. And we also have, for anaplasmosis, less than 8 hours has been published. This is important information. So the tick that just got on you in the last day could actually make you really sick. And the other problem is, myself and other authors have tried to publish confirmed cases of Lyme disease transmitted with a deer tick bite in less than 24 hours. And we were told by the New England Journal of Medicine that that's not information that's necessary for people to know, and they're not interested in publishing it. They didn't say that our paper wasn't good. They said that information is irrelevant. So we need to really stop censoring the medical literature as well. So let's dive right in. Anaplasma comes from a deer tick, and ehrlichiosis, like we said, you can get from a Lone Star tick. We have acute onset of fever with a headache and myalgias, malaise. These are kind of your common flu-like things. We might have low white cells or platelets and elevated liver functions, and these are early things that we have to look for, and it's important to know that these are rickettsial infections that can kill you. So if you have this, you need to be treated quickly. So ehrlichiosis can be diagnosed with antibodies and PCR, and under this, under Ehrlichia, I listed there's a few new ones out there that we don't even have testing for that we could do at Quest or at IGeneX or anywhere else. So these are research things, and hopefully we'll get that. But some of our people who look like they have Ehrlichia and Anaplasma may actually have it, and they might test negative because it's a different species. And then Anaplasma, same thing, antibodies and DNA. So the problem with a lot of the rickettsial infections, these two, Rocky Mountain spotted fever and the like, is that they can cross-react, and they can also cross-react with some of these other things up there. And also, I heard a question earlier to Bob about the blood supply and stuff. And the thing is, anaplasmosis and babesiosis can be transmitted through the blood supply. So this is really important, so that if you donate blood, you could actually give it to somebody else, or you could get it through a blood transfusion if they're not careful. Treatment is with tetracyclines. Generally, we're going to use doxycycline for a minimum of 3 days until the fever after the fever goes away, and at least 10 days. I generally treat a bit longer than that. And if we have problems tolerating it, or if the patient happens to be pregnant, rifampin is another good option. So Rocky Mountain spotted fever. If you look up here, there's a little state I come from called Connecticut, 0. Here's New York. It's the second darkest number, 1.5 to 19 per 1 million. That's a lot. So you guys are up there, and Rocky Mountain spotted fever is certainly present. Again, this looks so dissimilar to all the other things that you can get when you go to school. Like my daughter comes home with the sniffles and nausea and vomiting, right? So I mean, flu-like symptoms, but we can get severe headaches with this, and certainly a lot of muscle pain. Other things that can come are this petechial rash that we'll talk about in a minute, abdominal pain, joint pain, and diarrhea. So what we're going to see is a lot of these rickettsial infections are going to be looking a lot like a cross between the acute flu and maybe a viral gastroenteritis. So when you have those two things, particularly in the summer, but any time of the year when someone might be exposed to a tick, it's something to consider. So this is how the rash starts. Okay, about 35 to 60% of people are going to get the Rocky Mountain spotted fever rash. It's going to be a little flat. It's going to be kind of pink. They might have a little raised areas to it, and it's going to be non-itchy. All right, so then after 6 or 7 days, you might go to this, and this is the petechial rash. And this rash, the problem is it indicates very severe disease. And Rocky Mountain spotted fever can be fatal, and this is a really not good thing to see. Other thing, so what we want to do is we want to diagnose this thing fast. The gold standard is antibody testing. Unfortunately, it's undetectable for a week or 10 days in most people. So it's essentially not helpful. We have other testing available, but those take even longer. We can use a blood count and a liver function panel to see white cells and platelets down and stuff like that, and that can help your doctor out. The CDC, if you go to their website, because that's a valid place to get information these days, they say, hey, clinicians must diagnose and treat based on clinical suspicion alone. I thought like last week they told me not to do that, and this week they're telling me to do it. So the thing is, we really need to make sure that we're treating the patient and not the lab test, because in Rocky Mountain spotted fever, they could be dead before we make that decision. And in other things, we're going to set people up for chronic lifelong illness, and I prefer to prevent that. So the treatment is doxycycline, period, end of story, in everybody. We should start it as fast as we possibly can. And then right here, the CDC has sort of a campaign going on because everybody's worried about staining of the teeth in tetracycline use. It actually has not been shown to really happen. It happens to a few people, but it's really uncommon. So short courses of tetracyclines are fine. Children are 5 times more likely to die of Rocky Mountain spotted fever than adults. So we need to treat them. And just on the sidebar is if there is actually a new technology that if you got gray teeth from tetracyclines, you can fix it. Here's Q fever. Again, if we look over here at Connecticut, I don't have to worry about this too much unless somebody comes from New York, where again, you guys are up in the upper echelon. So this is another thing from those Lone Star ticks that we really need to be aware of. So again, this looks like everything else I've told you so far. It's a flu-like illness. It might be a viral type of thing. The big difference is you can get these high fevers as much as 104 or 105. So all these rickettsial infections and things like that that are coming from some of these ticks really start to look very similar. The thing is, also there's some confusion that can happen with this, probably related to that high fever. And the other thing about Q fever is you can get chronic endocarditis that might come on a year or 2 later. We diagnose this with antibody testing. We can do PCR, or the IHC is immunohistochemical staining. We can also get low platelets. And unfortunately, again, we can get false positives on this and Rocky Mountain spotted fever and other things like that. We want to treat it again with tetracycline like doxycycline and start as soon as possible. This one they recommend even starting it within 3 days if possible. And we might have to add a drug like a quinolone or rifampin to it to really get these people well. If they have endocarditis, we might need to add Plaquenil to our doxy and treat them, forget this, over 18 months. This is published guidelines. And then the other thing is we might have to add rifampin and or quinolone or both of them to get these people successfully treated. So there is evidence out there that we need multiple drug protocols. If we switch gears over to Babesiosis, this is a genus of over 100 different species of tick-borne protozoans. These things go into the red cells and parasitize it. They're very much like malaria. and our symptoms are going to turn out to be like that. In the United States, Babesia microti and Babesia duncani are the most common ones for us to see. And the other problem with this one, like I said earlier, with Anaplasma, is it can be found in the blood supply. There's published information that shows that that this is very hardy in the environment, and it can have long-term persistence in its hosts out in the woods and on the grass and stuff. And Dr. Horowitz and Dr. Krause have published that Babesia can persist after short and long-term courses of antibiotics. And I'll just point out that Dr. Krause's work was done in 1988. So in 1988, he said this, and in 2000, he said not that. We just need to start following evidence, in my opinion. And that's going to be one thing I'm going to try to hammer home is there is evidence out there, and why don't we use it? The short and long-term persistence is known by the American Red Cross. If you have babesiosis, you've tested positive once, you can never donate blood again. So they know. If there was no risk of long-term persistence, why would they say they need blood? They want blood. They're asking for blood every day. They know. And then, again, like we said in the very beginning, Lyme and babesiosis co-infected patients have an increased severity and duration of illness. Babesia causes all these malarial symptoms like sweats and chills. We can get shortness of breath. One of the common things is air hunger. So people just don't feel like they can get this full deep breath in. So they're kind of, it's like they might not be short of breath, like huffing and puffing, but they just can't kind of get that air in. Rib pain and other bone pain is very common in babesiosis. And headaches, and particularly the headache of sort of a head pressure, like a band around the head. That's something that's really common, commonly reported in babesiosis. And then all the other things we're used to in tick-borne illness, sort of the myalgias and the fatigue and the pain in the joints and the brain fog, all these things are common. We also see depression and anxiety. We see insomnia. And there's this thing called dysautonomia, where we have a dysregulation of the autonomic nervous system. So the stuff that allows you to stand up and have a good heart rate so that you don't get dizzy and stuff like that, that can be set off. And Babesia can also cause gastrointestinal symptoms. I actually have one patient in my practice who I saw about 5 years ago, and she came in with ulcerative colitis and a positive Babesia test. And we treated her babesiosis, not to fix her ulcerative colitis, but by accident we also did that. So that was kind of nice. In the acute form and in the hospital, we generally do a blood smear and we look for the parasites. Most of us who are looking for more of a chronically infected person or just in the family practice office are going to be doing an IgM and an IgG antibody test. That's for Babesia microti. For Babesia duncani, we can send out to IGeneX, and I think the Sonoma Department County of Health in California. We used to be able to do that through Focus Diagnostics, which we got through Quest or LabCorp, but they don't offer that test any longer. You can do DNA, and also there's some RNA tests of fluorescent in situ hybridization that is available for Babesia. False negatives have been known to occur because there's such a huge diversity. There's over 1,000 species. So that's, something to think about, false negatives in the literature. Treatment is usually with Mepron or atovaquone with azithromycin, and Bactrim or TMP-SMZ is often added. If you're Dr. Horowitz, I think he calls it Septra. I think we went to different medical schools. But anyway, TMP. And then the ones in yellow up there are the standard ones. So the atovaquone and azithromax or clindamycin and quinine are sort of your standard medical treatments if you saw an ID doctor in the hospital. But we've also found that sometimes we use Malarone. Malarone is essentially atovaquone plus another antiparasitic along with something like azithromax. So these are all important things to keep in mind. Multiple authors have published that there's evidence for of resistance of babesiosis to our Mepron, so we need to use at least 2, if not 3 drugs. Unlike in Lyme disease, where there's no known real resistance that we can create, it's either Lyme is sensitive to it or not, and then it goes and hides and does all this other funky stuff. Babesia can become resistant to the Mepron if you start it and you don't also start other things, so it shouldn't be given alone. Other treatments that I've used, liposomal artemisinin. There's several different herbal formulas up there, like the ABAB, cryptolepsis. and things of that nature. Neem actually works really well. So in our office, what we generally do is combine things like the herbals with the medications to balance those things out. And a lot of times I find I can't get certain things done, and things like biofilms in Lyme and Bartonella, and who knows, maybe in Babesia, sometimes are really hard to get into with drugs. And liposomal artemisinin is sort of like a Trojan horse where we throw things in, so that's very helpful. We don't really know how to treat pretty much any of these things to make sure that we get a true cure. But what we do know is that the lifespan of a red blood cell is 3 to 4 months. And it takes Mepron about a month to get to therapeutic levels in your blood cells. So it does make sense that we might want to treat for 4 to 5 months rather than 10 days, as other people have recommended. Bartonella can be transmitted by fleas, lice, sand fleas. It's been found in Ixodes ticks, the deer tick, and I also, there are published cases of it being in spiders, and I have a lot of people from Brooklyn, of all places, who, the folks I get from Brooklyn literally have like 75% of them who think they have Lyme have Bartonella. And they're like, where did I get it all? And the best we can come up with is spiders. And so hopefully I'll have some more on that in the future, because we're trying to study that and actually isolate that. But other things, Bartonella we commonly know as cat scratch disease, so you can get it through cat bites. Again, blood transfusion is a great place to get this, unfortunately. And this bug hides inside of cells. And when it hides inside of cells, it's sometimes really difficult, 1, for your body to find it, 2, for your antibiotics to find it, and for your testing to find it as well. And there are published publications showing that if you're co-infected with Bartonella and some other thing, you're going to have a greater level of illness. So the big three that I'd like to talk about, Bartonella henselae is the thing that causes cat scratch disease. Trench fever can be caused by Bartonella quintana, and that in some of the world wars that was a big deal. And then there's this Bartonella vinsoni subspecies Burkhoffii, and this is really commonly known in dogs, and there are some reports of human infection with this. And the problem is, with this human infection, the family got infected, and mom gave it to the babies, and they have direct evidence of maternal fetal transmission of this subspecies, and there's a question of sexual transmission of that subspecies. This is the common pustule you get if a cat scratches you or bites you. That can also lead to sort of swollen lymph nodes in the armpit. You can get fevers with that. It's at times been shown to cause bacteremia, or the bacteria can go through the bloodstream. You can get endocarditis. You can get liver problems. You can have bone problems caused osteomyelitis. So you start to think about it. You're like, well, if Bartonella can cause problems with my bone and I have bone pain, is all bone pain babesiosis? Maybe it's not. And neuroretinitis. And neuroretinitis is sort of the least common retinitis. And it's one of these things that shows that this organism can go to your eye and negatively impact your eye. Other things are the myalgias and the arthralgias, that muscle and joint pain that everybody's used to, but you can get headache, fatigue, poor stamina. The things that make it different than some of the other things we talked about, tremors, transient migratory muscle fasciculation. So somebody gets, I got one here, then it goes to my leg, and then it goes to my calf. The Bartonella can do this. Migratory peripheral neuropathy. You're numb and tingly in one place one day, a couple days later it's numb and tingly somewhere else. Also, a lot of people report alcohol is a problem after they've had a Bartonella infection. And there's this thing about foot and heel pain. Everybody's like, oh, if it's heel pain, it's Lyme or Bartonella, and if it's the whole sole, it's the other one. And I've never seen anybody be really clear on which is which, and no good studies on that. But what I do know is that when you have Lyme disease or Bartonella and your feet hurt really bad and you get effective treatment, it goes away. So I don't know if it's one or the other, or it might be both. Other things we see are neurologic involvement, cognitive impair, so the brain fog. Also, a lot of slowing of the executive functions, the things that let you get work done. Your working memory is poor, delayed processing speed. Bartonella tends to be really lead to labile mood, and also there's a horrible thing called transverse myelitis that's been reported. Bartonella is one of these things I see a ton of in kids, and I think we should look for in all our folks who have anxiety and depression. But when children especially, we see these acute personality changes. They're fine one day, and then they're totally different the next day. it's like overnight they become OCD. They're great until they're 8, and then all of a sudden it just completely changes. This wonderful child who's very calm, all of a sudden is out of control with rage. Regression is really common. So, somebody who's 8 years old and performing above grade level now is performing academically like a 3-year-old, despite their best efforts. It might be Bartonella. One of the most common questions we have about Bartonella is, does it cause these things? And I don't know how well you guys can see it. It looks a little washed out. But these violaceous striae, or violaceous stretch marks, a lot of people say this is normal. I don't know about you guys, but where I'm coming from, that's not normal, right? It doesn't look normal to me, and I don't have it on me, thankfully. And if my child or my wife had that, or I had that, I'd want to find out what it was, not just say it's stretch marks. And the problem with stretch marks in this is it's very commonly in very thin people, and it's huge, and that doesn't make sense. So where people started to think of, hey, is this Bartonella? These 3 Bartonella species, including Bartonella henselae, are unique in that they can actually cause the proliferation of blood vessels from pre-existing ones. So what we think happens is blood vessels will grow into these things. The problem is this has been done in immunocompromised people like those who have HIV. So we're not really sure. So when we look at the evidence out there, we did find one study, this is immunohistochemical staining, could show Bartonella in these stretch marks. And these are a picture, and what they did is they checked that, and they were able to visualize Bartonella henselae organisms. But then they tried to get the DNA of Bartonella, and they were unable to find it, and this has been unreproducible. So there really is no clear evidence that Bartonella does this, but what I can tell you is clinically, in people who have tick-borne illnesses, Bartonella, Lyme, Babesiosis, if they have stretch marks, we treat them and we see them start getting better. Very commonly those stretch marks go away. So, something to think about. We generally diagnose these things like we do everything else with the antibodies. We have the ability to do different types of DNA PCR testing, and then there's some fluorescent testing as well. Important information for all of us who get a chance to look at our own labs or are talking to our doctors. 1 to 256 or greater in IgM or IgG is strongly suggestive of an acute or a recent infection of Bartonella. And IgM almost always goes away very quickly. And most people think of IgM as the acute phase and IgG later. The thing we have, this is Up to Date, which is the most conservative sort of consortium of people keeping the doctors up to date, as the namesake is. But the idea is we go there and we find out what's going on. And this is the latest evidence that has been combed over by all the conservative folks. And they should follow their own information here. So greater than 1 to 256, you might have an infection. The other thing is we know there's a high false negative rate. And that means the test might be negative. We treat them for 4, 5, 6 months, and all of a sudden they have a positive test. And you're like, wow, where'd that come from? Did I get a new infection? A lot of times it's just from before. And that Vinsoni burkhoffii species, we don't even have a test that we can do on people at the moment. So treatment with Bartonella is kind of confusing. So usually what we do in people is, like if you have a urinary tract infection, we take a sample and we grow it, so we culture it. And once we grow it, we put antibiotic dots on it, like little tic tacs of antibiotics. And what kills it, it's sensitive to. What doesn't kill it, it's resistant to. And so that, not always, but usually works out just great. And then we give you the medicine and you get better. Well, that's called in vitro. And then in vivo, which would be in the mammal host, the dog, or in us, that usually works. But in Bartonella, all bets are off. So anything they do in the lab, that doesn't mean it's going to work. So all these things have been up on the screen, have been used in the past, including, believe it or not, the cephalosporins, which most people say can't treat it. But the thing that we found is that we really probably need to double cover and most likely double intracellular drug cover for any clinicians out there. But we need to use 2 drugs like doxycycline and rifampin, doxycycline and TMP, doxycycline zithromax. I heard Bob talking earlier about Levaquin. And there is some discussion of maybe Levaquin can work by itself. Based on all the literature I've seen, most drugs used by themselves, again, in a laboratory setting, will lead to resistance in 2 generations of the Bartonella. I'm not real willing to risk that, so I'm going to go and I'm going to treat people with at least 2 drugs for this. And when I put things together, I think that we need to really think about what we're doing. So, and what other organisms are there? Do I think the person's co-infected with Borrelia miyamotoi? Do I think they have Babesia? And that way, maybe I can get 2 or 3 different organisms with 2 drugs rather than 5 drugs. So I can minimize the amount of antibiotics somebody's exposed to while maximizing the coverage I have. In our practice, like I said earlier, we often use a lot of things like herbals, and these are some of the formulas we've used. And that also, in addition to the artemisinin for the biofilms, we found in Bartonella and Brucella, liposomal oil of oregano is actually working quite well too. And again, you know, like I was saying, like I really appreciate Dr. Jones and Dr. Horowitz as their mentorship and their friendship through all this. And as I get a little bit older in the profession and more experienced, we sort of bounce ideas off each other. Dr. Phillips and I were working on the oil of oregano stuff. I got him in the artemisinin. He got me in the oil of oregano. So we're all out there really trying to help so that our patients are going to get the benefit of us being science nerds. So again, Bartonella, you know, the treatment duration is unclear. There's a very high relapse rate if you treat for less than 15 days. So I would recommend we treat somebody till they're symptom free, and then usually we say, hey, give it another couple of months just to make sure. But most importantly, let's reassess our patients. And if you had a pneumonia and you came in to the hospital, because this happened to me when I was a resident, and you had a pneumonia, I give you an antibiotic and you got better, and then I took you off that antibiotic 10 days later, and 3 days later you call my office and you say, hey, I have the exact same symptoms. I don't even see you. I give you more antibiotic, or I change your antibiotic. This is normal. This is what my attending physicians told me to do, and that's what I would do. So, but if I take you off of a Lyme treatment or a Bartonella treatment and you flare up 3 days later or 2 weeks later, now you magically have post-Lyme syndrome, even though you were fine when you're on the antibiotics. It just doesn't, it's unlikely to be that. It's more likely that you have a relapse because we know that relapse rates are really high, so that our retreatment has been published to be necessary. And so what I'm saying is let's not wait 3 or 4 months to go, wow, I think they have the same recurrent thing. Let's just get people back on treatment and hopefully just extend it right from the beginning so we don't have to worry about that. Borrelia miyamotoi is a bug that unfortunately has become near and dear to my heart. I see lots of it. It's in the United States. This bug is transmitted by the deer tick. Infection rates can be as high as 15%. And this is the first Borrelia species that's been transmitted transovarially. So usually what happens is the Lyme nymph has had a blood meal, and so it's infected. The adult Lyme tick has a blood meal, and it's been infected. But then when the mom has the little ticks, the larva is not infected. And it has to have a blood meal before it becomes infected. In Borrelia miyamotoi, mom can transmit this infection to the tick, to the baby tick. So the concern here isn't so much that the larva is going to be biting you, because they probably aren't. But the problem is we're worried that as time goes on, we're going to have greater and greater and greater infectivity rates because they don't need their blood meal doesn't have to be on an infected host. You know, so they can just it can keep skyrocketing. And the study that I showed earlier from New York State, all the ticks that had Borrelia miyamotoi also had Borrelia burgdorferi. Here's a study that can help support that notion as well. Dr. Lee, as well as Dr. Landsman and myself, published this in 2014. And by the way, all 14 of these people were diagnosed with DNA, so they had active infection in the last 2 days in the month of February, when we had a winter unlike this one. It was very cold, so they shouldn't have been getting new tick bites. What you see is all 4 of these folks who are circled were diagnosed with Borrelia miyamotoi. But the one in the middle there, here, had co-infection of Borrelia miyamotoi and Borrelia burgdorferi. And this gentleman down here, who happens to be one of my 7 people in here, he was previously DNA positive for Borrelia burgdorferi before we had Borrelia miyamotoi testing. He had not been rebit, and there wasn't much of a change. So I think what happened was he was probably co-infected also. So it's something to think about. This infection is kind of going to look like a cross between anaplasmosis and Lyme disease, maybe Babesia. We're going to have recurrent high fevers with drenching sweats and chills. Certainly the headaches and the neck stiffness that come along with these kind of infections will be present. Fatigue and all the other stuff. Confusion has been reported, ataxia, so imbalance and inability to walk properly, and hearing loss. I've seen this in my patients, I've seen it in other patients, it's been published in the literature. So you could lose your hearing from a tick bite. And these people need IV antibiotics, and they usually do quite well. And like I had mentioned earlier, we may not be able to tell the difference between this and Lyme and Anaplasma and such. There's a couple of case reports and some series out there in the literature that these people were diagnosed with having anaplasmosis and anaplasmosis and anaplasmosis. When we got testing for Borrelia miyamotoi, they found Borrelia miyamotoi. So at the time that that study was published, there were 25, including those 4 cases, there were 25 cases of Borrelia miyamotoi in the country. Since that time, we've got about 150 to 200, and then they went back and looked at old serum and found about another 150, so it's like 300, 350 people. But I've got about 30 of them, so unfortunately I know a lot about, something we don't know much about. The other thing I know about this, though, is Borrelia miyamotoi is part of this group of relapsing fever Borrelia. So we can have all kinds of weird rashes that kind of look like that Rocky Mountain spotted fever rash. And then the EM rash, or erythema chronicum multiforme migrans, can be caused by both Lyme disease and Borrelia miyamotoi. So now my problem is when I see this bullseye rash, what is it? Is it Lyme? Is it Borrelia miyamotoi, or could I have both of them? So testing is not really routinely available. We can get serology through Imagen. We can get DNA testing through IGeneX and Milford Molecular Diagnostics, but that's about it. There's hopefully some serologic testing will become more available. That's the antibody testing, but that's where we're at. So Dr. Barber, who's associated with the IDSA and with UpToDate, said that, hey, the antibody test, if you can even get it, is usually negative. And so therefore it's most useful to confirm a diagnosis retrospectively. So later on we go back and look at it. So empiric, which is the physician's clinical judgment, empiric diagnosis and treatment might be required. Other things that we can look for is the low platelets, the low white cells, the elevated liver functions, like all the other co-infections we've talked about. And interestingly, if somebody has what we call meningoencephalitis, we think there's a problem with the brain or the tissue surrounding the brain, there's an inflammation. And we do a spinal tap and we look at the fluid. Generally speaking, in Lyme and in Borrelia miyamotoi, the antibody test is negative, the DNA test is negative. That's the most common finding. So when people do a spinal tap and tell you you don't have Lyme because it was negative, they don't know what they're talking about. So in fact, people who write against chronic Lyme all day long taught me this in the hospital. And so the thing is, if you have positive blood tests or a positive clinical presentation, the most common thing is to have a bunch of lymphocytes, maybe a little elevated protein, and a negative spinal tap otherwise. So it's super important for people to know. This is readily available. So Borrelia miyamotoi, we treat, again, our best guess of the whole 300 or 500 cases worldwide we have now are tetracycline drugs. And what you'll notice, I put some of these doses up here because they're not your standard doxycycline 100 milligrams twice a day. We're even being recommended to use 400 milligrams total in a day. And so that's kind of when I start to use higher doses because the pharmacology of doxycycline suggests that's what we need to do. We now have sort of the more conservative group saying, hey, we need to do that as well. You can also use penicillins and cephalosporins. They've done well. And if people have central nervous system involvement, we're using things like high-dose orals or intravenous. So that's important. And the other thing that I think is really important is in all the literature on Borrelia miyamotoi, they're like, if you have central nervous system involvement, you really need to extend the therapy. You have to extend the typical duration of therapy. And the other thing is, I have one of those ladies on that study said, unless you can sign a piece of paper that says I'm going to die in 48 hours, I refuse antibiotic therapy. I'm like, at the time there were like 18 cases of Borrelia miyamotoi in the country and about 75 in the world. And I'm like, you want me to treat you with what? So we actually treated her with 3 different herbal formulations, and she's phenomenal. She's like 95% better and been that way for over a year. So I've had success with the herbals as well as the antibiotics. One of the other infections we should think about is brucellosis. Not typically thought of the tick-borne infection, we think of it more as being in raw dairy, but if you look back in the literature, it's in ticks. And some of the experts in brucellosis think that you might be able to get it from a tick. It's very similar to Lyme and Bartonella in its presentation, but one of the things that really stands out is you can get inflammation of the vertebra, the spondylitis, but you also can get orchitis, and especially gentlemen with testicle pain very commonly have this, and it's very amenable to treatment. It might be a long treatment, which I'll get to in 1 second. Testing is poor, very poor. Across the globe we know this, and there's a huge literature on brucella saying the testing stinks, and also that you need 2 or 3 different intracellular drugs to get the job done. So if you look down there, combination treatment for 120 days fails 40% of the time. That's a long, that's 4 months of treatment, fail almost half the time. They're doing a little bit better if you do triple antibiotic coverage for 18 months. Most of those patients are getting better. Striae, which is another thing that can come from the wonderful Lone Star tick. I don't think it's been reported up this way, but I wanted to let you know about it. Also known as Master's disease, can cause an erythema migrans-like rash. Looks a little different, and it occurs, within a week or 2 after the tick bite. It looks sort of like Lyme disease. We have to clinically diagnose it because we don't even know what causes it. People get bit by a tick, they have a rash that looks like Lyme, and they get sick, and we have to treat them with tetracyclines or amoxicillin. Not super common, but common enough that the CDC comments on it, and we're still looking to find out what causes it. Here's another sort of rare infection, but I thought we should take a look at it because, again, I live in the safest place in the world unless you not want Lyme disease, because that's where you get it. But right here, 2014, CDC had 2 cases of tularemia. And tularemia is actually ultra common in Canada, which I found when I lectured up in Banff, so that was kind of disheartening. You can usually rabbits and rodents are infected. You can get it from from a dog tick, and you can get it from different fly bites, and also from animal and agricultural exposures. Again, fever, chills, headaches. The interesting part here is this one has sore throat and runny nose along with it, so that will help set it off a little bit. You can also get infection of the lung, which is quite bad, very serious. And then there's also ulceroglandular, which is much more common, and at the site of the tick bite, or the fly bite, you're going to see your skin ulcerating off. And that usually has swollen lymph nodes. So again, it's rare. I was going to actually leave it out until I found these cases in New York. We do antibody testing for it, and there's also some culture and some DNA you could do for it if you needed to. Hopefully no one in this room ever needs to know that information. We treat it with intravenous streptomycin or gentamicin, or we can use IV or oral tetracyclines or fluoroquinolones to get after that one. The general treatment is recommended for about 2 to 3 weeks, and again, I would probably extend this one a little bit as well. Tick-borne viruses, these things are in the news all the time. We're finding new viruses all the time. The problem is we really can't treat them. The best thing we know how to do is supportive treatment, and I know that Dr. Horowitz is going to talk a ton about that in his lecture, and I think that that's really something that we all need to be doing in all of our treatments, not just in our viruses. So one of the things I wanted to talk about briefly is to talk about kids, because kids are like, when you do pediatrics, they're like, kids are not small adults. Kids are totally different, okay? And they present with symptoms of Lyme that do not look like classic Lyme. And I was telling somebody this the other day, when you're in the beginning of medicine, like in the 50s, 60s, 70s, 80s, probably even in the 90s, everybody said, the guy would come in with chest pain. He had a heart attack. The woman would come in, she was crazy. She needed Valium. And so the problem was women came in with things that looked like chest pain, but not quite chest pain. And then what they found out was when they did more research is that, wow, women can have heart attacks and it doesn't look just like the man heart attack. And then they went and they found out that, well, most guys have heart attacks that look like women's, not like those other guys, right? So now we have atypical chest pain, but atypical chest pain is the most common chest pain. And atypical presentations of Lyme and co-infections in children is the most common presentation. Like in the Bartonella, abrupt personality changes are really give this away. And gastrointestinal complaints. I mean, I've had, it's like the kid who comes in, he's had every single, gastroenterologist in New York City put a scope in his mouth and his rear end, and nobody knows what's wrong with them. And so then you test them, you find they have a tick-borne illness, you treat them, and all of a sudden their isolated abdominal pain goes away, with antibiotics, mind you. And the other thing that's really interesting is I had a girl who presented with minimal anxiety and food allergies. Her mom said she couldn't tolerate about 45 foods. And I said, well, that's not a lot to go on, especially with Lyme, but let's test her and find out, because I had treated her sibling who was very sick and had gastrointestinal problems, and he did great. So we went for it. We found that she was exposed to Lyme. We treated her for 6 months with Zithromex, and she got all those 45 foods back minus like 3. So instead of killing her gut, we actually fixed her gut because we treated the infection that was bothering it. Other things that, see, I can't say this enough. Pediatric Neuropsychiatric Symptoms. It's like the #1 presentation, right? So these kids have that personality change, that regression. They're cognitively, they just totally go back several years. Their speech goes back. Emotionally, they're just losing it all the time. They have separation anxiety and panic, you know. OCD and anxiety. I mean, these kids who just all of a sudden went from nice and placid to can't handle anything, and they have these repetitive thoughts, rage and emotional liability. These things are super common in tick-borne infections. And one of the other things you'll see is the 10-year-old starts wetting their bed again. Or the 8 or 9-year-old comes home and you got a note from the school nurse that they wet their pants. But they've been potty trained since 3. So a lot of times what ends up happening is a thing called infection-induced autoimmune encephalopathy. And so this is a really nice way to put it. So the infection causes an autoimmune problem which goes after your brain. Right? And so that tells us the 3 main things that are going on here. Right? And all of these things up on the screen, the strep, the staph, the mycoplasma, Lyme disease, Bartonella, even in viruses can trigger this. And so a lot of people know this as PANDAS, or PANS, so pediatric acute onset neuropsychiatric disorder after strep, and PANS is after everything else. Right? And so, but I think what's really important here is that this gives us a roadmap, and infection-induced autoimmune encephalopathy is a Ray Jonesism. So Charles Ray Jones says this all the time. And why it's so important is it tells us how to fix these kids. We need to kill the infection, we need to turn off the autoimmune process, and we need to detox them so their brain can heal. So one of the things we do a lot of with kids is we try to minimize how many antibiotics they're taking, and we try to help them heal. So turmerics are great for autoimmune inflammation. You know, ibuprofen is great for autoimmune inflammation, especially in flares. I wouldn't use it all the time. Flex Now is a great over-the-counter that you can get that's been studied in over 33 trials. Almost all of it's in autoimmune inflammation. And a few other things. I've used low-dose naltrexone. And most kids don't want to hear this, but diet is actually one of the best things to do to get yourself better from there. So these are things that can help. And then detox, we use some liposomal glutathione. It's super to do that. Glutathione is poorly absorbable in the gut, so in the liposomal form it gets absorbed much better. There's a bunch of herbals that I use, from Pecana drainage remedies to some things from Byron White and Beyond Balance, really good herbal things. If we're going to spend all this time to get some of this out, and this even goes for like the people who do the saunas and the Epsom salts baths, if we're going to mobilize toxins, we also need to bind them. I use Takasumi as a carbonized bamboo. You can use activated charcoal. Cholestyramine or CSM can be very helpful. There are other clays like bentonite clay and a bunch of other things. But if you're going to mobilize those toxins, make sure you bind them up, because the thing you don't want to do is dump the toxins into your gut and have your gut reabsorb them. So you've done all this hard work, and now the kid has to basically recycle their toxins, which jacks up their inflammation. So the take-home message for co-infections is that they're super common. And when we see them, there might be an increased complexity to our diagnosis and our treatment. These people are more ill the more bugs they have, and they generally need treatment for a longer period of time, much harder to diagnose at the labs. Pediatric presentations are often bizarre, and I mean, I've seen kids hide under my table in the room. I've seen kids stabbing other children with pencils and forks in the middle of class. I've had patients where the child decided they needed to murder one of their siblings, and only one of them, and only some of the time. It was most of the time, but it wasn't all the time. You know, so we have to look for this infection-induced autoimmune encephalopathy, because when we get the inflammation down, we get the toxins out and we kill the underlying infection, these kids do great. And with that said, I mean, great, I don't want to overblow it. Some kids and some adults really have a super hard time with this too, and that's why we need to look at these, a comprehensive view of what they have. And one of the things is with co-infections, if people are not getting better when you're treating them, you have to look for what you missed. This means a doctor needs to be humble. And I like to use an integrative approach so that I am getting down that toxin load, getting the inflammation, turning it off as best we can, and also treating that root cause. But one of the things is if I set up an inflammatory cycle, this is really common in chronic pain. We have, after a while, you have an inflammatory cycle that basically replicates itself in the absence of the original cause. And I've seen some people where they're not infected anymore. And we need to do these other things to help them get better. We'll actually talk about one in a minute. So I want to shift gears just a little bit here to try to bring sort of the unique philosophy that I grew up in medical school into this whole thing. And so Dr. Still started with osteopathy, and he said, the object of the physician is to find health. Anybody can find disease. We can all find what's not working, but how do we find the thing that allows our body to heal itself? So to be able to talk about this some more, we have to know, well, what is disease? Well, it's an abnormal condition of structure or function, but Wikipedia has a great one. It's some or all of the body is affected. It could also be a lack of ease or harmony in the body. So the World Health Organization defines health this way: a state of complete physical, mental, and social well-being, not merely just the absence of disease. So when we see our patients, particularly our children, but everybody, we have to find out what's going on in their lives. I mean, I can't tell you how many people are going through divorces, and when they figure out that they're getting divorced, they tank. And I understand that, but that doesn't mean they need more antibiotics necessarily. That might mean I need to call on somebody else to help them. So one of the things I usually say in the beginning, but I should pause and say right now, is I'm usually introduced as a Lyme specialist, which is the furthest thing from the truth. I'm a family practice doc who wants to help people get better. And if they have Lyme disease or a chronic tick-borne infection, I'm going to treat it. Just like if they're allergic to gluten, I'm going to tell them to get off of it. So the thing is, we really need to look at that really broad palette and find out what's really impacting the person in front of us and treat each person as an individual. So another definition: balanced condition of a living organism in which integral, harmonious performance of the vital functions tends towards the preservation of the organism. So our body is always moving towards being healthy and staying alive. So here's Still again. He loved anatomy and he was checking out this all the time. But unfortunately what happened in the mid-1800s is many of his family members died of meningitis. And he was like, well, why did this happen? And he looked at modern medicine. They're giving strychnine and arsenic and mercury, and people were getting sicker. Bloodletting was common. Although if you go to my office, that might happen too, with all the blood tests. But, and so he said, look, there's got to be he tried to inject common sense into medicine. And then he also said, oh, by the way, if you use hands-on treatment, people get better. And they all laughed at him, so he created his own profession. And in 1892, he had his first class at the American School of Osteopathy with women and blacks and other people of minority status, which, for 1890 was pretty rockin'. So anyway, he came up with these crazy ideas like, hey, like the body is a unit of body, mind, and, the person is a unit of body, mind, and spirit. And you can't treat one of them, you have to treat all of them. And in fact, words ruin this because you can't actually treat someone physically without touching on all parts of them, and we really can't separate it out. He said that the body tends towards health. It has a self-healing, self-regulatory mechanism. Structure and function are related to each other. So if you break your leg and you start limping, that's going to change the way you can move toxins out of your pelvis. And then let's inject some common sense, and if we believe in these top three, let's apply them in the clinic and create rational treatment protocols. So I wanted to kind of bring all this together with a couple of cases to show you how I use some of this. So I had a 55-year-old woman who's like, I don't even know how many times I've had Lyme disease. And she she sees a great doctor. He calls me all the time asking for help, so I pick up the phone because that's what Dr. H and Dr. Jones did for me. And, she wasn't really responding. And his question and the patient's question was, do I still have chronic Lyme disease or what's going on here? So she had severe debilitating headaches. She gets Botox, she gets Nardo, which is horrible, and methadone. And she goes to a world-renowned migraine clinic, and they're like, methadone, like, we give nobody. She flies up to Chicago once a month to get a prescription for a narcotic. Her headaches are so bad. But she also told me she has bilateral temporomandibular joint dysfunction. So when I first saw her, she looked gray. I mean, and based on the amount of treatment she had without detox, she was in bad shape. And so, you know, she got IV glutathione, and that night, as I see many people already reading because I hit the button too soon, her daughter, like, she tells it straight, she just, like, they sat up for 4 hours on her daughter's bed just crying and crying and crying. I have my mommy back. And all we did was give her a simple one-time IV glutathione. Subsequently, she's had some more, and she went from driving 8 minutes maximum for 3 years to about after 4 infusions, which take all of 7 minutes to do, to driving an hour and a half one way to my office when her husband couldn't bring her for an infusion. So remove the toxins. The other thing is she had temporomandibular joint dysfunction. So if you have horrible headaches and your TMJ doesn't work, well, that's a cause of headaches. And when you have a patient who's been treated for chronic Lyme and they're not responding and they've been treated by somebody who knows what's going on, maybe we should look elsewhere. So I suggested I treat her osteopathically, and we also look at using a functional orthodontic appliance. She very quickly saw a change in her headaches when I put my hands on her body. And there's a change in character and intensity, and she said, oh, by the way, my bowel works better. Like, well, that's kind of good, because your bowel has 70% of your immune cells in an adult, and 50 to 60 in the kids. So if we're not peeing and pooping, or we're pooping too much, we're not going to have an optimal immune function. And if we think about the skin, which is continuous with the colon, it's the largest organ of detoxification in the whole body. So that's massive in a toxic person and anybody else. And she hasn't seen the dentist yet. But she's doing so much better just with a couple of shots of IV glutathione and a couple of treatments where she lays on the table and wakes up feeling better. So I have a 12-year-old girl that I've been seeing recently. She came in with fatigue and headaches, blurry vision, dizziness, and all of this really got worse when she was reading. So she has pain like all over her body. It sounds ridiculous. I mean, this time she comes in a walker, she comes in a wheelchair. One day she's up, the next day she's laying down in her bed. So, and with all of this, being a 12-year-old who wants to go to school and everybody's yelling at her parents and her parents are yelling at her, she's getting more and more anxiety. She had had Lyme disease 3 or 4 times, and she got antibiotic treatment, did really well. In fall of last year, she sort of had the same thing happen again. So she went to the same ID doc, put her on the same doxycycline, and she got a little better, came off, got worse, and this kept going on, and she got treated 3 or 4 times last fall. But then everything sort of stopped getting better, and then she actually started to worsen. So she came to see me. I found, so this goes back, if you're not getting better, check for co-infections. We found Lyme, we found Borrelia miyamotoi. And remember that 1 to 256 Bartonella henselae? Well, we've got 1 to 1024 here. So this is all really important things to think about. We have to look for co-infections. Again, look for co-infections. So I started her treatment. She started to get a little bit better. But then she flared up, and she wasn't able to go to school. So I was on the phone with the school forever. And this is like, you have to do it because you want this kid to do well, but it's so time-consuming. And so I finally got them to agree to give her a home tutor, but the problem was they wanted 10 hours a week, and she could only do 2. And they were like, well, why is this? And they didn't really know what was going on, and even though we were talking to them left and right, and I was calling them every other day, they reported the parents to the state. And I understand where the school's coming from, but at the same time, they could have talked to us, and I mean, the parents really were trying, but they were getting frustrated with the school. And this happens especially in children all the time. So we decided to assemble the team. So the top guy is me. The second one is a neuropsychiatrist. We had a neurooptometrist and a licensed clinical social worker. And we decided to figure out how to answer the questions that the school had that we hadn't been able to answer yet. So she was a highly motivated person who had a very high IQ, like ultra high IQ, but she had significant neurocognitive impairments that prevented learning. So, and then the person who did her neuropsych testing said, hey, the discrepancies you see in the neuropsych test, that's common in tick-borne illness. So when you don't fit the pattern that you're used to seeing in these neuropsychiatric because usually the way they're built is they test you 6 and 7 times for the same exact thing. And when you see things that don't fit a normal pattern, that's very common for tick-borne illness. And most people just say, oh, the kid didn't try. But there's things in there that prove they tried or didn't try. So, important. The optometrist saw the person and he said, look, the tick-borne illness destroyed her visual spatial processes. So she, especially when she was reading close, she couldn't tolerate things. So she had increased postural tone, which led to pain, particularly in her neck, but throughout her entire body. And then she had this thing that you hear a lot of us talk about is convergence insufficiency. So if I ask you to look at the pen and focus on it as it comes in and you get double vision or blurry vision, she has that problem. And then her muscles would spasm. And so she wouldn't be able to remember things, she couldn't continue to focus on things, and this would drive her pain through the ceiling. So when the tutor said, do 10 hours of work a week, it was actually making her sicker. So the goals of the school, which we have to keep in mind, were to keep her in school, even if it's only a few hours, so it's social. They wanted full participation and in the standard tutoring, and it was kind of like following the mold. Everybody's got to follow, it's just easier if we follow the mold. But our team goals were to treat her as an individual. And we wanted to find out what was really going on, and we have to have a unique approach. So we need a special ed tutor, somebody who can say, look, today she's doing well, tomorrow she's not doing so well. She can't do this for hours and hours on end because she physically can't do it yet. She's going to get prism lenses to help hold, help her eyes and take some of that strain off, and she's going to be coming in for osteopathic treatments. And of course, we want her to go back to school. I mean, most 12-year-olds like hanging out with their friends. They might not like the school part, but school's where you get to hang out with your friends. So she wants to go there, and we want to help her get there. So moving into our last cases here, we're going to start this one with a smile, because the face and the smile tell us a lot about, it's really the primary way we communicate with people in the world. Oh. So, what about this one? Or that one? So, most of us, when we see those previous two pictures, say, fix it. Something's wrong, I know how to fix it. I'm a carpenter, I have a hammer, let's fix it. The question that I have is, why does everybody have to look this way? Maybe we could ask the question of, what's the underlying problem? What is going on that's leading to that open bite we saw and all those teeth being all over the place with malocclusion? So why don't we look? Why don't we ask ourselves? I don't know how many people know Napoleon Dynamite. But what's he telling? What are mouth breathers telling us? How many people do you just like, when they're on the bus or when they're when you're seeing them in public? How about this kid? Well, maybe his head forward posture is because he's using all these computer games, right, and playing on the internet. Or maybe there's something else going on. What about this kid? This is pretty normal, right? So what is that? What's that telling us? And how about all of our kids who are bruxing, grinding their teeth, our autistic kids who chew on everything? Why don't we look into this a little bit deeper? So first impressions are very important. So just think about what you're thinking about this little kid here. These are his teeth, and what you'll see, if you can see this here, it's got a cross bite, right? And you're like, well, what the hell does this have to do with tick-borne illness? Almost there. This is a cone beam x-ray of this little guy. And what you might be able to see is his head's not on straight. The way they do this is they put your jaw in something and then they strap you down, but they don't strap your head so tight you can't move. So it gets a little bit of the function of how people are doing. So you see he's tipped. And if we look up, so this is his right forehead and his left forehead. That's his spine, and his cervical spine, and here's his jaw. So his right forehead's really prominent, and his jaw is really kicked off, and none of his cervical vertebrae line up. Again, what does this have to do with tick-borne illness? Well, this is his airway. It's supposed to be green. This is fancy math with colors, but it's supposed to be green. Yellow's bad, red's really bad. Okay, and so the problem here is this kid has a really high level of airway resistance. So he could have obstructive sleep apnea with that, SIDS, where kids die from this. So again, what does this have to do with tick-borne illness? Well, the #1 symptom of sleep apnea in children is night sweats. Interesting, huh? So if we look at this patient here, we see a very beautiful smile. It's pretty straight. It's way straighter than mine is. But I don't know if you can tell in the back there, see how the teeth are canted in? They're real tight. And I know this person pretty well because that's my daughter, Talia. All right, and so Talia would have profuse drenching sweats, like she has acute Babesia or malaria every time she went to bed. Change, wake up, drench, take, an hour to dry off if she wouldn't let us towel her off. If she fell asleep in the car seat, dripping wet, like literally covered. Everybody's like, hey, Tom, you're a Lyme doctor. I say, wait, not a Lyme doctor. But they said she has to have Babesia or Borrelia miyamotoi. And I said, well, her mom's a doctor, her dad's a doctor who does this all day long. I'm pretty sure she doesn't have it. But the question is, well, what else could she have? And she could have sleep apnea. So one of the things that we did was we talked to a functional dentist who put this thing in. It's an advanced light force functional appliance, or light wire functional. And basically, this was developed by a dentist to help support the natural healing processes in the body and the natural developmental processes, going back to the definition of health. The goal is to develop the face anteriorly and down. We put this thing in literally that night, no more sweats. You can't develop a face that fast. The reason it worked is because it's helped support your self-healing mechanism, which can do anything it wants to heal you. So when we tap into that power, we're in good shape. And here's Talia. And this is January of last year, and you can see her eyes are sort of looking up because her head is tipped down, and look at her ears. Now, not even a year later, you see that she's more upright. Look at her eyes, they're looking out there, and check out her ear. Now, part of her ear tip is going to be because her head's up, right? So her head, so I understand, but also there's actually, when you do all the angles, her ears have rotated back. So her temporal bone has moved, and your temporal bone is the thing that can affect dizziness and vertigo and your balance. So how many Lyme patients have dizziness, vertigo, or balance problems, or night sweats? And then this is just a quick plumb line, and then a picture through the forehead, through the maxilla, which is the upper jaw, before and after. And because you see the closing of that angle from wider to smaller, you see that that maxilla has moved forward. And that's a more normal posture. So something to think about. And then this is Talia getting her alpha adjusted, and usually I check her head and see what's going on, and the dentist said, oh, don't get up, let me do it. So while this is in there to remind everybody that while our health is super serious, let's not take ourselves too seriously. Let's have a good time, all right? And that's our buddy Lenny Condell from Stanford. And there's Talia enjoying an osteopathic treatment. And that's just because I'm lecturing and I get to show a picture of my kid. All right, again, so what does that have to do with tick-borne illness? Well, I had a 6-year-old come in, and she'd been ill for a couple of years. She couldn't wear clothes on her lower extremity. She wore these big bag skirts, which I'm sure, dresses, I'm sure they have a real name, but I'm a guy. Horrible noise sensitivity, horrible hypersensitivity to smell, the hyperosmia, tantrums, hyperirritability, and when she went and urinated, she would wipe and wipe and wipe and wipe and wipe and never felt like she was dry, even though she was dry. She was diagnosed with Lyme and pandas and pans by multiple physicians. She was treated with cephalosporin and a macrolide antibiotic, Suprex, and Zithromax, and she had amazing improvements right off the bat. Then they added Bactrim because they thought she might have Bartonella. Again, she had ongoing improvements according to mom and the charts. But what I also noticed when I was talking to them was they put her on sertraline or Zoloft 6 months into this. So while she got dramatically better, she was still pretty sick. And I don't know, but I'm pretty sure I've never put a 6-year-old on Zoloft. I try not to, at least. So, she did better and better incrementally for the next 9 months or so, but then she got worse. And so they started changing around her antibiotics, and that stuff really didn't work. So then they came to see me for a third opinion. So she was pleasant and clingy with mom, but what I noticed was her diaphragm didn't move much, and she had a super high, narrow palate. Kind of looks like that. You can play with yours with your tongue and see if it's anything like that. So again, this made me worried about an airway issue. Mom wanted to do some herbal treatments, so I gave her some CBD oil and some liposomal artemisinin. She had a bit of a flare, and then anger and rage. She's very easily frustrated, super mean to one person, her brother. And then she started developing really bad stomach aches. So then with that, her mom decided to take her off all the antibiotics without asking anybody, talk to a psychiatrist, and put her on Abilify. Abilify is an atypical antipsychotic, which when I was a resident in the hospital, they said, don't put anybody on it without the psychiatrist signing off, because you're taking your life and their life in your hands. Now we advertise it on TV and everybody takes it, including 6-year-olds. So I changed her treatment. I put her on some herbals. We did some detox, and I recommended she see my buddy who was sitting on my lap in that picture, and also get some osteopathic treatment. She didn't do that. She changed some herbals around on her own and started playing with the MTHFR stuff, and she took too much B vitamins, and we finally were able to get that under control. But she then was out of school, and then the psychiatrist said increase the Abilify because the atypical antipsychotic is not working on a 6-year-old. So, and she hasn't seen me for manipulation or my dentist. So the long story short was, after all this, Mom said, whatever you said, I'm going to do it. She comes in, I treated her 3 times, manual therapy, and then she saw the dentist and had this ALF placed for 2 weeks. So that's not too much time. She went back to school, and she started wearing clothes again, 3 times per week, which is better than 0. She came off of Abilify within 5 months. So I think that's pretty cool. She continues to improve, and recently I saw her, and she actually got an acute sinus infection, and she flared up a little. So usually my kids with pandas and pans flare tremendously, but when we support their airway and their natural healing mechanism, they tend to do a heck of a lot better, and she continues to be in school. So what is she teaching us? Well, one of the things are we must treat the infections. The Lyme and the co-infections must be treated. But we also have to look at other things, because co-infection is just something else that's going on in the body. And so a lot of times I'll call it a co-toxin, right? Because there's more things. There's stressors in your environment, there's airway problems, there's food problems. So treatment of the musculoskeletal problems is just another piece of that. And the airway is super important. It's like we have this in CPR, we have A, B, C. Well, airway's first. There's a reason for that. So we need to get air into these folks. And the other thing is support the self-healing mechanism. It can do a whole heck of a lot of things that we can't do as doctors. So a friend of ours gave me this quote from her mentor, and it said, to bring health, to heal is to bring a person into the state of well-being and wholeness by using love and breath. So if we can focus on the airway and treat people with dignity and respect that they deserve as an individual, I think we'll go a lot further. So to wrap up all the things we talked about, tick-borne illness and tick-borne co-infections are super common, and we need to be on the lookout for them. But as I showed you, some of the things that look like tick-borne illnesses are not. And many odd presentations, particularly in our children, are in fact tick-borne illnesses, and we have to have our awareness high. We have to have a high index of suspicion. And if we can, let's find health. Let's look for that balance and harmony. That's our natural state. All it takes is a small change in our perspective, and we can get that stuff done. This is a picture of Talia being treated osteopathically by me. She did this about 1.5 years or 2 years ago, and the caption reads, "I love you, Daddy, because you make me healthy." So kids innately understand that our natural state is health, balance, and harmony. It's not this disease thing. Our doctors got that down. We have to start looking, towards moving to the healthy spot rather than the other thing. And if everybody in here would think about that and consider finding health in their own lives and in the lives of their patients and their friends, I think it'd be a great success and we'll all get better a lot faster. Thank you.